Today, we're going to be talking about hypothermia protocol post cardiac arrest. This project is brought to you by Brenna Battle, Tishan Bowen Gordon, Dana Dunlap, Megan Smith, and myself, Morgan Staney. Before we really get started, I just want to go ahead and talk about some learning objectives with y'all. After this educational presentation, nurses and us as future nurses should be able to do three things. We should be able to verbalize understanding of how the hypothermia protocol improves a patient's outcome following cardiac arrest. We should be able to summarize the main steps in initiating the hypothermia protocol post cardiac arrest. And thirdly, we should be able to discuss changes to be cautious of when inducing hypothermia in these patients. Um, Post cardiac arrest patients, as we should know, are particularly unstable, and any slight change could be detrimental to them. For this presentation, our area of educational focus in Bloom's taxonomy will be in comprehension. So a little bit of history about inducing hypothermia. It was not always a protocol, and it was not always used to treat cardiac arrest patients. Originally, induced hypothermia was used by ancient Greek physicians to treat patients that were hemorrhaging or had traumatic injury. Most early use of the hypothermia was used with cardiac intracranial aneurysm surgery patients, and this is the most early use in hospital settings and more modern settings of medicine. The lowest recorded body temperature to be successfully resuscitated was a skier. They were trapped under ice and their core temperature was 13.7 degrees Celsius. That is extremely cold. So currently, we do use therapeutic induction of hypothermia for patients that are post-cardiac arrest. We also use it for patients that have head or neurological injury and in neonates, particularly neonates with encephalopathy. So what is the hypothermia protocol? Before we really get into what the protocol is, we're going to talk a little bit about what it is not. Therapeutic induction of hypothermia is not the same as cryotherapy. Cryotherapy is more of a musculoskeletal intervention. It's typically used for athletes, anyone that puts their body through hard work, and it's more therapeutic in that aspect. Whereas inducing hypothermia is a little bit more in depth and a little bit more harsh on the body than cryotherapy. So the protocol itself. The hypothermia protocol involves deliberately reducing the patient's core body temperature to a targeted temperature range. This range is typically 32 to 36 degrees Celsius. This is done only if he or she does not regain consciousness after return of spontaneous circulation post cardiac arrest. So you really only initiate this protocol if the patient goes into cardiac arrest, that you do CPR, and the patient does have spontaneous circulation return, but they don't regain consciousness. It is recommended to induce hypothermia on these patients for a minimum of 24 hours. In cardiac arrest, neurological brain injury begins in as little as 2 minutes. This is due to compromised blood flow and thus oxygenation and perfusion to the brain. Inducing hypothermia in these patients slows further cellular anaerobic metabolism, preventing the cellular excitability that leads to hypoxemia and cellular death in the neurological tissues. And as we all know, brain tissue, neurologic tissue, is non-repairable. So this injury, if not prevented, is permanent. And a side note, hypothermia protocol also reduces the inflammatory response to these tissues, but that's not really the main thing we look at this point. So why use hypothermia for patients that are post-cardiac arrest? So first, what you should know, a little background. There are approximately 300,000 people in the United States alone that have an out-of-hospital sudden cardiac event, particularly cardiac arrest. Even further, less than 50% of these people who develop return of spontaneous circulation survive. So realistically, less than 50% of these patients will survive their out-of-hospital event. The leading cause of death in these patients is anoxic brain injury as a result of prolonged lack of oxygenation to the neurologic tissues. So, the benefits of induced hypothermia. Therapeutic induction of hypothermia improves survival and neurological outcomes for these patients. In doing so, induced hypothermia reduces the metabolism of the cerebral tissues. It decreases blood flow to the cerebral tissues. And in doing this, it decreases intracranial pressure. All of these things really do help reduce or eliminate injury to the neurologic tissues. Inducing hypothermia also stabilizes calcium and glutamate release. This reduces the degree of cellular death that occurs. As mentioned a moment ago, injury to these tissues and death to these cells is irreversible. Inducing hypothermia stabilizes the blood-brain barrier and suppresses the inflammatory process. In doing this, it prevents hemorrhage as well as increased ICP, so increased intracranial pressure. So even with this, it also prevents further injury to these patients. So therapeutic hypothermia does increase survival post-arrest. So as mentioned previously, about 300,000 Americans suffer cardiac arrest outside the hospital each year. Of these 300,000 Americans, CPR will be attempted on about 40% of them. Unfortunately, typically less than half of that 40% will survive. So approximately 20% of 300,000 Americans or less will survive their out of hospital cardiac event. Therapeutic hypothermia is a really solid attempt to increase the odds for these patients. Doctors say people who would not have survived without the procedure are alive and free of brain damage today. So we'll go a little bit into how this works. Therapeutic induction of hypothermia begins with cooling. So the body is cooled with either a cold blanket or intravenous fluids, and sometimes even ice. It may be a combination of all three. In doing this, drugs induce a temporary coma in this patient. The cold therapy prevents damage to the brain that can result from blood flow restarting. So this patient is cooled, and after about 24 hours, maybe a little longer, we'll go ahead and rewarm the patient. This takes at least 8 hours. You don't want to rewarm the patient too quickly, as it can actually cause further damage to the neurological tissues and the systemic tissues if done too quickly than would have been done had you not cooled the patient at all. Who qualifies for therapeutic induction of hypothermia? The therapeutic induction of hypothermia is recommended for use in unconscious adult patients with return to spontaneous circulation after an out-of-hospital cardiac arrest, specifically when the initial rhythm was ventricular fibrillation or pulseless ventricular tachycardia. Patients with non-ventricular fibrillation and non-pulseless ventricular tachycardia, so AKA patients that have non-shockable rhythms, when they arrest out of hospital or in hospital, they're also indicated for this therapy. This therapy is recommended for use in patients that are intubated, so long as treatment is initiated within 6 hours after the arrest happens. This is key because 6 hours post-arrest is kind of the benchmark of sorts to where these patients very likely have irreparable brain injury that is beyond repair, and where the therapy will not be beneficial to them. So we're going to go ahead and talk about what therapeutic induction of hypothermia is not recommended for. It is not recommended for patients who have had major surgery or procedure within the past 14 days. It is not recommended for patients with systemic infection or sepsis, patients that were in a coma prior to their cardiac arrest. It's not recommended in patients with a known bleeding disorder or bleeding that is active currently. And it is not indicated for patients who are pregnant or patients with DNR orders. So how is hypothermia induced in these post-arrest patients? There are 3 phases to the therapeutic hypothermia protocol. There's the induction phase, the maintenance phase, and the rewarming phase. I talked about this a little bit earlier, but we'll go through it again. Induction phase is really just the phase where you initiate the cooling all the way to when the patient's desired core temperature is obtained. So it's from the end of your CPR to when your patient has returned to spontaneous circulation, but does not regain consciousness. You'll initiate the protocol per physician. Go ahead and get the patient set up to cool in the way that is indicated specifically for them, depending on their current status. Um, you're going to maintain the patient's core body temperature between 32 and 36 degrees Celsius once you get them cooled. So that'll be the induction of the maintenance phase. This phase can last up to 24 hours, maybe a little bit longer. You certainly don't want it to go any less than that to get the full therapeutic benefits. So once the patient has been resuscitated, cooled, maintained for 24 hours, then you can go on to the third phase, which is the rewarming phase. In rewarming your patient, you're going to rewarm them slowly to 36 degrees Celsius. You're going to do it in increments of 0.3 to 0.5 degrees Celsius per hour. You don't want to go any faster than this because rewarming them too quickly can cause blood flow to return too quickly. And unfortunately, too rapid of an increase in blood flow from these temperatures can cause further injury to the systemic aspects of your patient. It can cause further neurological injury. It can cause vessel damage. So we talked about the therapeutic induction of hypothermia itself. We talked about the protocols and history. So we're going to talk about now some equipment and drugs that you're going to need because you're definitely going to need both to get this done to the fullest extent. As far as equipment, for surface cooling of your patient, you're either going to need a cooling mattress, cooling blankets, a cooling helmet, or ice packs. You may need a combination of these four, just depending on what really your physician wants and what's indicated for your patient. For core cooling, you're going to need an intravascular heat exchange device and an IV infusion of cold fluids. To measure your patient's core temperature, which is a very important aspect of this protocol, you're going to need a bladder temperature probe and a pulmonary artery catheter. Other things you may need a ventilator. Your patient is going to be induced into a coma-like state. So they very likely are going to need that because they're not going to be breathing overly well on their own, if at all. As far as medications, you're obviously going to need a crystalloid for the infusion of the IV fluids. You're going to need a neuromuscular blocker and a sedative. So you're going to need a paralytic and a sedative to prevent your patient from shivering. These drugs typically are going to either be vecuronium, midazolam, or fentanyl. Just an aside to this, when giving a paralytic and a sedative, always, always, always give the sedative first. If you give your paralytic first, your patient is fully aware that they cannot move, that their body is no longer in their control, and that's terrifying for them. So always, always, do best by your patient, give them the sedative first. In addition to the sedative and the paralytic, you're going to need some lidocaine. This is specifically to prevent ventricular arrhythmias, which we all know can be very detrimental to your patient. So here we have a photo of a neonate. He is being cooled. As you can see, he is wrapped in two of these white blankets. Those are your cooling blankets. So inside those blankets is actually circulating cold fluid. And on his head, you see this white cap. It also is to cool him. It's not the same as these blankets. It doesn't have fluids going through it, but it does have a cooling mechanism that keeps the patient's head, head temperature a little bit lower. As we all know, there's a good bit of heat in that area. And on this picture, we have an adult patient who is being packed down with ice. So we're looking at the surface cooling aspect of this protocol. So as you can see, there's quite a few bags of ice. They're doing their best to get his body temperature down in a controlled way. So as far as interventions, for us as nurses during the cooling and maintenance phases, if you're using surface cooling, you're going to sandwich the patient into two cooling blankets. You're going to pack him or her in ice until the desired temperature is attained. You're going to specifically monitor for skin breakdown every 2 to 6 hours. As I mentioned earlier, your patient is going to be sedated and or paralyzed. So they are not going to be turning on their own, repositioning. So it's going to be really, really important to make sure that they are turned, repositioned, minimal layers of linen, just everything you can to make sure that they are not going to have any skin breakdown while they are under this protocol. You're going to keep your head of your bed at 30 degrees. You're going to want to obtain a 12-lead ECG to monitor for ST elevation. Even further, you want to monitor for signs of dysrhythmias. In these patients, bradycardia is the most common. It's very important to stop the treatment if dysrhythmias or bleeding arise, so let your provider know if there's any contraindications to this therapy that are happening, and let them know that you're going to have to cease the protocol. For these patients, it's important to maintain their MAP, or mean arterial pressure, above 80 millimeters of mercury and their oxygen saturation above 94%. If their MAP drops below 80, norepinephrine at 0.01 micrograms per kilogram per minute can treat that MAP and get it back to where it needs to be. It's a weight-based titration, so it's really important to get your math correct. Further than that, you want to keep your patients NPO, so nothing by mouth. Obviously, they're sedated. You're not really going to want to try to get them to eat or drink anything. As far as the rewarming phase, interventions for us as nurses, you want to obviously remove the cooling agents. You want to slowly, slowly, slowly rewarm your patient. 0.3 to 0.5 degrees Celsius per hour at the fastest for 8 to 12 hours. The desired temperature range for these patients is 36 degrees Celsius post rewarming. In this phase, it's important to monitor these patients for hypotension. When you rewarm them, their vessels are going from extremely constricted to extremely dilated. So when they vasodilate, they can have a sudden onset of hypotension, and that can present a whole new world of issues for you and for them. Further than this, you want to keep your paralytic agent and sedation being administered for them until they reach their desired core temperature. You want them comfortable. You don't want them panicking. You really want to do best by them and keep them sedated and comfortable until you reach your desired temperature. You don't want to rewarm them above 36 degrees Celsius. You want to avoid the hyperthermic state. Really, you're just trying to maintain equilibrium for this patient and get them back to where they really needed to be, which is kind of a homeostasis for them. And the desired core temperature is 36 degrees Celsius, no more, no less. So things to watch out for with this. There are adverse and side effects of inducing hypothermia on patients. It does increase the risk of sepsis, increases the risk of hypovolemia, so deficient fluid volume. It increases the risk for cardiac dysrhythmias that may or may not be secondary to electrolyte and metabolic imbalances. The patient may have cold sweats, non-septic infections. It increases your risk of coagulopathy, non-convulsive seizures, pulmonary edema, deep vein thrombosis, and even pneumonia. So, there are barriers to this. This protocol is highly complex. It does require one-to-one care. Timing is extremely essential. It's been shown that there's 20% increase in risk of death for every hour of delay in initiating this therapy. The therapy itself is case by case and is influenced by comorbidities. Training and experience of staff is key. It should only be initiated by EMS or the emergency department and continued in the emergency department or ICU respectively. Here are our references. I really want to go ahead and say thank you so much for listening to us today. It's really been great making this project for you. If you have any questions, you can drop me an email or text me, or even just drop a line on the discussion board. I'll provide my email in the discussion board post, and thanks again for listening.